Stephen Liu, the Director of Thoracic Oncology at Georgetown University, and just taking a moment to reflect back on ELCC 2025 held in Paris this year, brought to us by ESMO and ISLC. We saw a lot of practice-informing data here, and I think particularly in the EGFR space. The MARIPOSA overall survival results were presented by James Yang, and I do think these are practice-informing. We've known for quite some time that the combination of amivantamab, an EGFR MET bispecific, and lazertinib, a third-gen EGFR TKI, does improve progression-free survival for EGFR mutant lung cancer. Focused on that DEL19 and the L858R population, what we saw at this meeting was the improvement in overall survival. We had a bit of a teaser from press release, but here we see the concrete data. The projected improvement in median will be out over a year. We see Kaplan-Meier curves that really split after 12 months, and that OS hazard ratio 0.75, certainly meeting our bar for clinically meaningful and certainly a statistically significant improvement in survival. Now, it's true that this combination regimen does introduce infusions, does introduce more toxicity and really different practice, but I think less and less of a barrier. We think of dermatologic toxicity, but the Cocoon study, a supportive care trial also presented at the ELCC, show that different dermatologic interventions can reduce that dermatologic toxicity. We know that we need to use prophylactic anticoagulation, and that can help counter the venous thromboembolic events. And one might look at all these supportive care medicines and say it's a much more complicated regimen to deliver. But to be fair, we use just as many supportive care medications when we're delivering chemotherapy. It's just that's a regimen that we become accustomed to over time. It's probably time that we start looking closer at this regimen for more, if not most, of our patients. The big question that's still unanswered: will we see a similar or different survival benefit with the FLAURA2 regimen? And I think that could make the calculus a little bit more complicated. But for now, we do have a regimen that improves survival, and I think warrants discussion with all of our patients diagnosed with EGFR mutant lung cancer. For those that are already on osimertinib, we know that resistance is an inevitability. And how do we overcome that resistance? MET amplification, a common mechanism of resistance. And we did see Dr. Myung-Joo Ahn present the SAVANNAH data looking at the combination of savolitinib, a MET inhibitor, with osimertinib. And in settings of MET amplification, we do see fairly high response rates, up over 50%, and they're durable with durations of response anywhere from 7 to 10 months. MET amplification, it really depends on how you define that mechanism, but more and more, this is an actionable mechanism of resistance. Although, if we do shift more towards MARIPOSA in the frontline setting, this probably has less relevance because we don't expect to see a lot of MET-mediated resistance if we're using MARIPOSA in the frontline setting. We also saw very important updates from the LAURA trial, shifting to that locally advanced stage 3 setting. And while this study needs a little more time to mature, what we're seeing early on is very encouraging. We saw profound improvements in progression-free survival with the use of osimertinib after definitive chemoradiation. This is a setting where we try to cure patients with chemoradiation, but the data looking at the control arm tells us we do not cure very many patients at all with EGFR mutant lung cancer using chemoradiation. Adding osimertinib does seem to delay progression-free survival, but a big question: will that improve overall survival? Will this be better than using these drugs in sequence than waiting for progression? And the data are not yet mature. We haven't had enough events, which is, I think, a good thing. But we are seeing those survival curves start to split. And one has to believe with this profound, this degree of PFS benefit, that will translate to an overall survival benefit. This is not a disease that we can really wait to relapse or to recur. So this strategy does seem to be a winning one. Dr. Suresh Ramalingam presented this update, and I think that we'll wait to see how these data mature. But so far for EGFR mutant lung cancer, our treatments are getting more effective, more complicated, but that really comes with a more sophistication of understanding this disease space. And so a lot of excitement in that EGFR space, and really the promise of more changes to come.